Good afternoon, everybody. Can everybody hear me okay? Excellent. Well, we're going to go ahead and get started in the interest of time. Welcome for Friday afternoon, CF Endocrinology across the lifespan. I have no disclosures, our mandatory disclaimer. So we are very honored to chair today's symposium. Juan Pablo, who goes by JP Perdomo Rodriguez, is an adult endocrinologist at University of Florida in Gainesville. He's also an Envision 3 mentee. My name is Maria. My middle name is Socorro, and Suki is a nickname for Socorro, in case anybody's wondering. And I'm a pediatric endocrinologist in San Antonio, and I'm a former Envision 1 mentee. For this symposium, we'll have 4 20-minute presentations, each followed by 5 minutes of questions and answers. And then at the end, hopefully we'll have time for about 15 minutes of a panel discussion, just in case you have a last burning question, you can come up. You can also use the app to submit your questions. And the session will be recorded and made available on YouTube post-conference. We're really excited about this symposium. We're going to have discussions on updates of growth and puberty by Dr. Amy Daru, who's also an Envision 2 former mentee. CF bone disease will be given by Melinda Wu, who's also Envision 3 mentee. And Dr. Danny Velez-Leitner is going to be discussing male endocrine and reproductive health. And then JP is going to finish us up with modern CFRD. I've now mentioned multiple times Envision. This is a really wonderful program that is funded by the CF Foundation, and it's an acronym for Emerging Leaders in CF Endocrinology. I'm in that first cohort. That opened up so many doors. It's formal mentorship to lead a career in CF endocrinology. And with that, my mentor, Andy Kelly, mentioned in a car one day, have you ever wanted to be a physician scientist? I'm like, I have no idea what that is. Never thought about it. And then that led to, well, how does anybody do anything like that? And that led to going for a K. And then I applied for the Schwachman Award through the CF Foundation. So I'm under career development. That led to Protected Time to help develop a multi-center study called Spectrum. And I just received a reward for the CRISP Award to receive formal mentorship to lead a multi-center study. So all of these things, if you're a junior faculty, you're thinking about endocrinology, and you are thinking about a career in CF, this can open up a lot of doors. And then in cohort 2 and 3, you can see that we're expanding. You're like, really, all of those people are endocrinologists? No, actually, it has expanded. We have OB-GYNs, we have reproductive endocrinologists, and we have urologists. So it's such a beautiful time. All right, so let's go ahead and get started. And I am excited to have Dr. Amy Daru as our first speaker. She's a pediatric endocrinologist at Yale Medical Center, and she's going to talk about updates on growth and puberty in children with CF.
Thank you, Suki. Good afternoon, everybody. My name is Amy Daru. I'm a pediatric endocrinologist at Yale Medical Center. I'm very excited to talk to you today about growth and puberty, a topic that's near and dear to my heart, of children with children with cystic fibrosis. So let's get started. Just a disclaimer, and I have no disclosures. So as we know, CFTR is in pretty much all areas of the body besides the lungs. It's not just localized to the lungs. So it's localized in other areas such as the bone and even the brain. And so it does affect multiple other areas of the body, including it can have a big role in growth and puberty when there's a mutation in CFTR. So when the way I want to approach this is I'm going to talk to you first about growth and then move a little bit into puberty. And then I'm going to talk about some updates for both of those topics. So growth is a very important, thing that we look at in pediatric endocrinology, and in general in pediatrics. So for those of you who are not in the pediatric world, we use growth very much as a barometer of health. It tells us how is the patient doing, because a lot of times in pediatrics, a child might have a clinical diagnosis that is silent. And sometimes growth and falling on the growth curve can be the only sign that something might be wrong. So we normally, catch these things with our growth charts, but we always depend on families and pediatricians to be very vigilant about that as well. In CF, about up to 20% of people may have growth difficulties. It is defined in our pediatric endocrinology with a height Z-score less than -2 standard deviations below the CDC mean. We can also call it underweight, stunting, or wasting. The key time periods that we tend to look at are in utero, during infancy, childhood, and in puberty. There are multifactorial causes for growth failure, and it's important to look at all of those because growth failure is linked with very poor outcomes, including decreased pulmonary function, poor bone health, and most concerning, increased mortality. So when we look at the causes of growth failure, it actually can start in utero, which we'll talk about in a moment. But it actually, when we see children born with CF, they already, many studies have shown this as well, they tend to have a reduced birth weight. So they start off from very early on with a disadvantage. Throughout their lifespan, they have other conditions that can contribute to growth failure, including chronic infection and inflammation, steroid use, with the CFTR being located in the brain and in the bone. We may have growth hormone axis suppression. There's been some suggestion of impaired growth hormone or IGF-1 secretion, or maybe even a growth hormone resistance. These children oftentimes have anorexia during their illnesses. They often have insulin insufficiency, even if they don't have full-on CFRD. They have increased energy requirements, and then many of them, as you know, have pancreatic insufficiency and malabsorption. So during the different stages of life, there are multiple factors that contribute to growth failure. So for example, in utero, studies have suggested that CFTR mutations can lead to decreased growth hormone and IGF-1. They can lead to pancreatic dysfunction, and they can lead to placental dysfunction. There's also some thought that there's increased energy expenditure as early as in utero. In childhood, many of these children face meconium ileus, pancreatic insufficiency, lung infections, and lung structural changes. In later childhood, you have these same conditions, but then you add on things like nasal polyposis, CFRD, CF liver disease, GERD, depression and anxiety, and can be associated with disordered eating. And then in adolescence, we have we have studies that suggest that there might be a diminished peak height velocity and delayed timing of the pubertal growth spurt. Whether this is associated with low sex steroids or not is a little unclear. We'll talk about that in a little bit in a few minutes, about the conflicting studies about that. So, as we know, growth failure has a significantly big impact on patients, but there's other conditions that it causes other than just short stature. Growth failure in CF can cause reduced nutrition, decreased lung function, reduced lean body mass, decreased bone mineral density, increased hospitalization rates, and probably most concerning, there's an increased risk of mortality. So in one study that I've shown here at the table by Vieni and others, it's entitled Stunting is an Independent Predictor of Mortality in Patients with CF. They looked at 393 patients, and they found that the stunted patients, which they defined as a height below the 5th percentile, had a twofold risk of mortality. The children who were defined as wasted, which was defined as percent of ideal body weight for age, had a 5-fold risk of mortality. In Peds Endo, obviously, and even with the CF clinic in general, I think everybody's focus is always to first make sure we're maximizing our nutrition, making sure the child is having appropriate medications and appropriate BMI over the 50th percentile if possible. We do use growth hormone therapy in Peds Endocrine. It's not commonly used, but it is used by some endocrinologists more than others. We do have IGF-1 therapy, and of course the CFTR modulators have played a big role in treatment of growth failure. So now we go on to, So now we go on to puberty. As you know, puberty is something that can cause a lot of emotional distress for many children, whether you have CF or not. And so you add on complications like cystic fibrosis, and it's a very difficult and challenging time for many of these children. The timing of puberty is very important. It impacts linear growth, it impacts bone mineral accrual, and body image and psychosocial well-being as well. If you're an adolescent already going through adolescence and you have CF on top of it, and you have delayed puberty, it can be emotionally distressing for the patient. The prevalence of delayed puberty in healthy individuals is about 5%. The studies are all over the place, I'll be honest, with puberty and CF. We have studies that say that there's no difference from healthy individuals in the percentage of delayed puberty, all the way to 20 to 60% of children with CF have delayed puberty. For those of you who are not pediatric providers, just a brief overview of what constitutes puberty. For females, we consider the start of puberty to be normal anywhere between the ages of 9 to 12. Thelarchy is the first sign of puberty in a female, always. Peak height velocity is generally about 6 to 12 months before they have menarche, and delayed puberty in a female is considered absence of breast buds by age 13 years, or primary amenorrhea by age 16 years, or primary amenorrhea greater than 4 years after thelarchy. For males, the start of puberty is anywhere between the ages of 10 to 13. Testicular enlargement is the first sign of puberty in boys. So pubic hair is nowhere in here, which you'll notice, which is often a referral to us. But it's thelarchy for girls, testicular enlargement for boys. Peak height velocity is about 9 centimeters per year at an average age of 13.5 years. Delayed puberty in boys is defined as absence of testicular enlargement by age 14, or a long lag between testicular enlargement, penile growth, or pubic hair development. So on this slide, I put this together as sort of a timeline of all the studies examining whether there is pubertal delay in CF. And I did this because I wanted to kind of show that this has been examined for many decades now, and there's a clear pattern that's going on. When we start back in 1964 up at the top and go all the way to the current day, you can see that the original studies, all the way pretty much up into the 2000s, were pretty consistent in showing that there is pubertal delay in CF. However, as we started to get into this century, we started to notice a little bit more of a conflicting sense of whether there is delay in puberty. There's some papers that suggest there is delay, and some papers that suggest there isn't. So the reasons for delay are numerous. We know that children with have an increased risk for pubertal delay if they are homozygous delta F508 mutation, they have poor nutritional status, have an abnormal OGTT, or have diminished lung function. But we must also consider the possibility that other things may contribute to pubertal delay, such as increased energy expenditure, ovarian dysfunction, and then remember, CFTR is located in the brain, and there's a high possibility that it may be impacting gonadotropin levels. Menarche is also one of those things where I think previous studies suggested there was a significant delay. The older papers suggest that there was a delay of about 14 and a half years old for menarche on average, whereas healthy individuals were at 12.9 years. However, again, the more recent studies suggest that delay may be closing, likely due to improved therapies. Some studies have suggested that up to 52% of children with CF have menstrual irregularities, and then some studies have suggested that CF may actually increase, those with CF may actually have increased exacerbations just before or during their menstrual cycle. So delayed growth and puberty have long-lasting effects well into adulthood. For example, if you have delayed or decreased sex steroids, you're going to have low bone mineral density, which is going to increase your risk of fractures. If you have increased fracture risk and pain and decreased mobility, this is going to result in increased pulmonary morbidity and mortality. Long-term complications also include emotional distress and psychosocial well-being. There have been studies that have suggested that delayed puberty decreases self-esteem and increases the feelings of isolation and being different in those with CF. Fertility is impacted as well, as we know in CF, mostly in males due to the congenital bilateral absence of the vas deferens. And in females, CFTR mRNA is found in the uterus, the fallopian tubes, and the cervix, and it can cause a thick, impermeable cervical mucus. Once again, our go-to is always to try to improve nutrition in these patients. However, if that is not sufficient, we will consider estrogen replacement in females and testosterone replacement in males. And of course, the CFTR modulators have impacted the outcomes of delayed puberty as well. So now I'm going to move my talk a little bit to the updates in CF. I'm going to first start with growth, and I'm going to tell you a little bit about some of the recent studies that have gone on with growth. I'm going to talk about other areas of treatment and investigation that are going on, perhaps related to growth, perhaps not. We don't know at this point. And then I'm going to end a little bit with talking about the BEGIN and the PROMISE study. So when we talk about recent growth study, so growth studies have been going on for decades in CF, but I'm going to be talking about some of the more recent ones that have come out. Many of the recent studies in 2023 and 2024 have really focused on the early years and how that impacts later life. So, for example, this one study by Soter and others looked at early growth trajectories and their impact on lung function. They looked at 6,809 children, and they divided them into 6 discrete trajectories. So either they were growing always, their growth parameters were always low, or they were considered a rapid decliner, a gradual riser, a rapid riser, a gradual decliner, or always high. When they later looked at FEV1 scores at age 6 for these children, the highest FEV1 scores were consistently for those who were in the always high growth trajectory. When they looked at the always low growth trajectory, these children had about 10% decrease in FEV1 levels at age 6. They also looked at what CFTR modulator therapy in such a young age does for final height, and they found that for both males and females, it did significantly improve final height at age 18. Patil and others is another study that I looked at, and this also looked at younger children between ages 0 to 6. This study looked at the weight for length over the 50th percentile between the ages of 0 to 6, and they found that those who did maintain a weight percentile over the 50th percentile had earlier peak height velocity and growth and greater heights as adults. They also, this study is the one that also looked at CFTR modulators and found that they have improved heights at age 18. The next thing I'm going to talk about is the impact of the gut microbiome. This has been something that's been looked at for the last few years, and there have been a couple studies that have shown about how this may or may not impact growth in CF. Again, we have conflicting studies. This particular study in 2016 by Yan and others suggests that the gut microbiome may induce IGF-1. However, later studies in 2023 and 2024 suggest that the gut biome has little influence on growth. We've also heard a lot these last few days about gene therapy. As you know, 10 to 15% of our patients who are not eligible, for CFTR modulator therapy. There are genetic therapies being explored, including gene addition therapy, RNA-based therapies, antisense oligonucleotides, and gene editing. CFTR plays a role, as we know, in growth and puberty, so it remains to be seen if, when gene therapy becomes a reality, if this affects growth and puberty parameters. There's also been some talk in the meetings the last few days over using CFTR modulators in pregnancy. There have been animal studies and case studies that have suggested that by giving CFTR modulators during pregnancy, this has had significant impact on the fetus and can potentially reduce and or even eliminate CF-related pathology for the fetus. There's the PROTECT group, which is basically a project that's looking at goals and agendas for further studies to figure this, if this is something that could be a potential future therapy. Just as an extrapolation, perhaps if this is something we start to do, then this could also affect growth and puberty in the future. The BEGIN study is a study that's still ongoing. It's a two-part, multi-center, prospective, longitudinal exploratory study. Began in November 2020 and it'll end in 2029. There's a part A and a part B. It is looking at multiple factors of multiple areas of effects of CFTR modulators. However, in terms of the endocrine area, we are looking at growth factors and height. It's assessing whether height for age Z-scores will change over time with CFTR modulators. We don't have any solid results at this time, but early results are showing that it does suggest an increase in weight, but not in linear growth. The PROMISE study is a study that just recently finished, and it is also a multi-center prospective observational study looking at CFTR modulators. This study is more in older children. The BEGIN study is in younger children. And the endocrine impact of CFTR modulators, it's looking at insulin requirements, hypoglycemia, bone mineral density and body composition, growth velocity Z-scores, and endocrine growth factors. The endocrine growth factors that it's looking at are body composition, IGF-1, and IGF-BP3. So the updates on puberty specifically. Puberty is not something that's highly studied with CF. So we have few and far studies that have come out on that. So it was exciting to see a few recent ones. Most of the recent studies basically looked at the fact of early identification of delayed puberty and menarche and found that there may be actually some relation to increasing fertility for these patients if we identify delays in puberty and menarche. They looked at CFTR modulator therapy, and they've shown that it shows a decrease in the delay in menarche, decreased menstrual irregularity, and decreased painful symptoms. Paula de Souza Diaz Lopez and others looked at an interesting study recently that looked at pelvic ultrasound findings and Tanner staging and suggested that there's less pubertal development in girls with CF compared to the controls. So these were my updates on both growth and puberty, and let me know if you have any questions. Thank you.
Great job, Amy. If anybody has any questions, please come up to the mic. I don't see any questions in the app either, but I have a couple of questions. You mentioned that some people use growth hormone therapy. I've used growth hormone therapy, but all of the patients actually formally failed a growth hormone stimulation test. Mm-hmm. Is that your experience as well, that you're really only using it with formal diagnoses, or are other people getting it approved for other indications?
That's always a question that's tricky because it's always dependent on the insurance, of course.
Yes.
And we all know how fun that could be. The overall, I think you're right. We obviously have a much better chance of getting growth hormone approved in these children who fail the growth hormone stimulation test. But, I have been successful in, perhaps appealing and using the idea that there is significant evidence that there is growth failure in these children. And, I have had success in getting children growth hormone despite passing the growth hormone stimulation test. So, and it's been successful.
And I have one more follow-up question. So I work in San Antonio where 50% of the patients self-identify as Hispanic. I was just wondering, in your comprehensive literature review, is anybody starting to look at racial and ethnic differences in linear growth in CF?
I know that there's been studies regarding racial and ethnic differences in general with CF, mm-hmm. but I don't know of any particular studies looking at growth, no.
Okay,
not at
just
this time.
Wondering, since social factors like poverty tend to influence linear growth. Just wondering.
Correct.
Open opportunities then.
Thank you.
Well, thank you so much. It was a really beautiful presentation.
Thank you.
And, a beautiful question. So is there any evidence that ETI has corrected any delays in puberty?
So I think there's the word evidence is tricky because it depends which study you're reading. Some studies, like I showed in that timeline slide, suggest that yes, there has been a significant closure in the gap between healthy individuals and those with CF regarding delay. And that is being attributed to the fact of improved therapies, including CFTR modulators. However, there are studies that suggest that there still remains a delay. So I don't know if we have an exact answer on that.
Yep. TBD. Okay, so our next presenter is Dr. Melinda Wu. She's a pediatric endocrinologist at Johns Hopkins University, and we have tasked her in presenting CF bone disease from childhood to adulthood.
Thanks so much for this opportunity to talk about one of my favorite topics. So we're talking about CF bone disease from childhood to adulthood. My most important disclosure is that I am also an Envision 3 mentee, like everybody else. So cystic fibrosis related bone disease. I think that in this audience, we all know that this is characterized by low bone mineral density and an increased risk of fracture. So when we look at fractures of the long bones, we see that people with cystic fibrosis are having more fractures than people without cystic fibrosis. Specifically here we have a German single center study in which studying people who were 6 to 34 years of age. The bar on the top, that's the healthy controls, and the children with cystic fibrosis were having a 9-fold increased risk of fracture. It's interesting that all of these fractures in this study were low trauma. And the probability of having a fracture by age 25 years in this cohort was 60%. In our single center experience at Johns Hopkins, we have 25% of our children 0 to 21 who are followed in our pediatric CF center have had a fracture. You can see that they're fracturing at all ages, and those two blue squares actually represent vertebral fractures in an 11 and a 14-year-old. Now, it's important to note, and I'll get to this later, 19 of these children had their first fracture before age 8. Now, vertebral fractures are typically considered an osteoporotic fracture. And in radiologist review of clinical chest x-rays of healthy adults with cystic fibrosis at Emory University, 27% of adults with cystic fibrosis have had a vertebral fracture. Here we have an older study by Aris et al. From 1998 showing that men and women have significantly higher prevalence of vertebral fracture than their healthy controls. You can see age-matched healthy controls is pretty much a 0 vertebral fracture rate, and they have significantly higher rates of rib fracture as well. Looking at Cystic Fibrosis Foundation patient registry data, we can see that the prevalence of bone disease, including osteopenia, osteoporosis, and fracture, is increasing with age. We can definitely see an increase in this around age 18 when universal DEXA screening is recommended. Now, 8% of adults greater than age 18 with cystic fibrosis have osteoporosis in the registry. When looking at healthy people without cystic fibrosis, 20% of the women over age 50 will have osteoporosis and 6% of the men will have osteoporosis. And so people with cystic fibrosis are having an increased risk of osteoporosis compared to healthy controls as well. Now, there's a lot of factors at play here, and bone is a very complex organ undergoing continuous remodeling, balancing both bone formation as well as bone resorption. One thing I really want to emphasize here, and echoing Dr. Dar's point, that CFTR is expressed on the key bone cells, so both our osteoblasts and our osteoclasts, as well as the osteocytes, enabling communication between these cells. The most potent stimulus for bone formation is mechanical loading, activating our Wnt signaling pathway. And many hormones are also involved in maintaining our bone mass, both inhibiting bone resorption as well as stimulating bone formation, including the active form of vitamin D, calcitriol, to ensure adequate calcium absorption. Now, there are many factors that are going to contribute to bone disease in people with cystic fibrosis. Overall, they're going to have more bone resorption than bone formation. So again, CFTR is expressed on all of the key cells involved in this, our osteoclasts doing bone resorption, our osteoblasts doing bone formation, as well as the osteocytes communicating in between our cells. There is a higher rank ligand to osteoprotein ratio in people with cystic fibrosis compared to healthy controls. And so what does this mean? Rank ligand is going to bind to its receptor rank on the pre-osteoclast, thereby resulting in pre-osteoclast differentiation into mature osteoclasts, which are going to be resorbing bone. Also, inflammatory cytokines are going to be, again, stimulating this pre-osteoclast to osteoclast differentiation. And some people with cystic fibrosis, again, as Dr. Daru was just highlighting, will have lower levels of sex steroids. And so androgens and estrogens are going to be inhibiting that activation. And so it's like taking the foot off of the brake pedal there. And so net, we have more osteoclast activity in people with cystic fibrosis. Now, mechanical loading, as I mentioned, is the most potent stimulus for bone formation, and our patients with cystic fibrosis are often less physically active, doing less weight-bearing activity than peers without cystic fibrosis, and so thus they're having less of this stimulus. Hyperglycemia and insulin deficiency is going to inhibit the differentiation of the pre-osteoblast into that mature osteoblast. So again, less bone formation. And then the majority of patients with cystic fibrosis will have exocrine pancreatic insufficiency and thereby then vitamin D deficiency and then a reduced ability to absorb the calcium necessary to mineralize the osteoid. And so you may have wondered, why is a pediatric endocrinologist talking about bone disease? It's because this is a disease of childhood that is manifesting in adulthood. So inadequate bone accrual can cause the osteoporosis in adulthood. And while this kind of figure is often shown as, say, suboptimal lifestyle factors, we all know that cystic fibrosis is not a lifestyle factor, but it is resulting in decreased bone accrual during childhood. And then even during this young adult period, when you should be maintaining your bone mass after they've attained their peak bone mass, they're having decline in their bone mass even before they get into the age in which they're having more age-related osteoporosis. And so osteoporosis is a combination of decreased quantity and poor quality of the bone, which results in decrease in bone strength that can increase the risk of fractures. So I've talked quite a bit about the decreased quantity measured by bone density in people with cystic fibrosis, but high-resolution peripheral quantitative CT, which is a specific type of imaging modality mostly used in research, reveals that there is abnormal bone quality in people with cystic fibrosis. Now, this is high-resolution peripheral quantitative CT of the distal tibia in a woman with cystic fibrosis who does not have low bone density and a woman of the same age without cystic fibrosis. And you can see that there is differences. The cortical rim is thinner. There's more space between the trabeculae. The trabeculae themselves is thinner. There's more porosity. And high-resolution peripheral quantitative CT, sometimes called a virtual bone biopsy, gives us the ability to estimate a failure load, and failure in bone is a fracture. And the failure load of people with cystic fibrosis is lower, meaning less force would be needed to cause a fracture. So now I'm going to shift gears and talk about DEXA to measure bone mineral density and other imaging. I'm going to first start with some definitions that, again, I think everybody in this audience already knows, but just want to make sure we're all on the same page. So when we think about premenopausal women and men less than the age of 50, this includes children, we're talking about a Z-score. And the Z-score compares our age and sex matched controls. Normal bone mineral density is between -2 and +2. So low bone density for age is less than -2. -2. However, in cystic fibrosis and some other select populations at risk for osteoporosis, we recognize this at risk for low bone density category, a Z-score between -1 and -2, as a population that is more at risk and needs closer monitoring. Now, when we talk about T-scores, we're comparing not to your age and sex matched, but actually to peak bone mass attained by young white women. And so this is used for postmenopausal women and men over the age of 50. So normal bone density is a T-score greater than -1. Osteopenia is -1 to -2.5, and less than -2.5 is a densitometric diagnosis of osteoporosis for these postmenopausal women and men over the age of 50. So now definitions of osteoporosis. We talked about densitometric. Now what about for those people who are less than 50 or premenopausal? It's the combination of two factors. One is low bone density for age, so a Z-score less than -2 plus a clinically significant fracture history. Now that's slightly different if you're a child versus a young adult. And so for children, it's a vertebral fracture, a low trauma fracture of a lower limb long bone, or more than 2 upper limb long bone fractures. Now for our young adults, it's just one low trauma fracture. So, why do we really care about this? We have our Cystic Fibrosis Foundation CF bone density screening guidelines, last updated by RS et al. In 2005. It recommends universal screening for all adults who are over age 18 with a DEXA scan and children 8 to 18 years who have specific risk factors. And then the follow-up DEXA should be based off of that baseline DEXA bone mineral density Z-score. Now, the reason I'm showing these other guidelines from other countries is to just highlight that it's only the US who recommends universal screening starting at age 18. The rest recommend universal screening starting at age 8 to 10. And the follow-up screening interval is based off of either the bone density or the age, similar to what we are doing. Now, what sites, where should we be measuring our bone mineral density? So for pediatrics, we recommend the lumbar spine and the total body, less head. And for adults, it's the lumbar spine and the hip. And so you may find that if you just order a normal DEXA, that you may not get the total body, less head for kids because it's an order that's intended for older adults. Now, again, Dr. Dora really just set me up for this talk. A lot of our patients with cystic fibrosis are a little bit shorter. And so if you are short stature, then the bone mineral density that is measured, that Z-score, can underestimate what their actual Z-score is. And so this is an individual with another genetic condition that causes short stature in addition to her cystic fibrosis. And so we can see here, total body, less head, that Z-score is less than -2. So she has low bone density for age. However, when we height adjust it, we find that her bone mineral density is actually -0.8, so she has normal bone density for age, and we'd recommend her next DEXA in 5 years. Now, we've talked a lot about measuring bone density, but what about some other ways that we could evaluate bone health? And so that's actually lateral spine x-rays to evaluate for those vertebral compression fractures that is going to be an osteoporotic fracture. And so we do this by measuring the anterior, middle, and posterior heights on a lateral spine x-ray. And depending on the amount of height loss between each of these heights, whether it's 20 to 25% or 25 to 40 or greater than 40%, we then call it a mild, moderate, or severe vertebral compression fracture. And this is example data from a patient with glucocorticoid-induced osteoporosis who has 2 severe vertebral compression fractures. So I've now talked about 2 imaging modalities for cystic fibrosis-related bone disease, one of which is DEXA and one of which is a lateral spine X-ray. Now, if your center is anything like my center, you are not getting DEXAs quite the way it's recommended. So what about another imaging modality? What about CT scans? So at our site, we have 800 patients who've had a CT scan, about 3/4 of the patients, and they've had 4,000 CT scans that can visualize the spine, versus less than half of our patients have ever had a DEXA, and we have a little over 1,200 DEXAs. And so what we're actually trying to do is use these scans and establish CF-specific norms for volumetric bone mineral density as a opportunistic measurement. And we can also assess for prevalent vertebral fractures. So we've got our preliminary data from 50 CT scans, with 3,500 more to go. Now I'm going to shift gears and talk about some management of CF-related bone disease. Bisphosphonates is the drug class that has been most studied for people with cystic fibrosis, and it shows that multiple studies have shown that there's an increase in bone mineral density at multiple DEXA sites with bisphosphonates, oral and intravenous, for people with cystic fibrosis. But the data about decreasing fracture rate, the actual failure of bone, has been more equivocal, and this is probably relating to the small sample size of these studies. I do want to note that one of the intravenous bisphosphonate trials was terminated early due to bone pain, which is a known side effect of intravenous bisphosphonates. So how do bisphosphonates work? They induce apoptosis of the osteoclast. Remember that cell that's responsible for bone resorption. And they're part of the class of medications that are anti-resorptive. There is another potent anti-resorptive medicine called denosumab, which is a rank ligand antibody. And there is an active clinical trial led by Dr. Raksha Jain in UT Southwestern, where they've enrolled 10 people into an observational sub-study of denosumab to follow them over 1 year and see what happens in terms of bone imaging and bone density as well. Now, bone is a complex organ that is continuously undergoing both resorption and formation. So there are some medications that can promote bone formation, the PTH analogs and romosozumab. These data are all case series, and they've shown increases in bone density, but have not shown any change in fractures. This may again be small sample size or limited follow-up. Now, to follow Dr. Reyes's question about use of other medications, growth hormone, testosterone, and estrogen, these are weekly osteoanabolic medications. However, we really recommend using them to treat hormonal deficiencies if you are trying to promote more bone formation. And we do have an ongoing observational study looking at different forms of estrogen supplementation in young adults with cystic fibrosis to see how that changes their bone density accrual. Now, we've talked about pharmacotherapy for cystic fibrosis-related bone disease and osteoporosis, but it's really important to think about the non-pharmacological ways that we can improve our patients' bone density. So optimizing diet, optimizing lifestyle, including making sure that they're getting as much weight-bearing activity as possible. For children, this is 60 minutes of moderate to vigorous physical activity every day, avoiding cigarette smoke exposure, alcohol in moderation, avoiding bone-toxic medications like glucocorticoids, but also proton pump inhibitors, H2 receptor antagonists, SSRIs, loop diuretics, as well as making sure that puberty happens on time. But also specific to our patients with cystic fibrosis, if they are pancreatic insufficient, we want to make sure that they're getting their pancreatic enzyme replacement, taking their vitamin D with their enzymes as well as with a meal, and ensuring that they're getting adequate protein intake. Now, it's really important to make sure that we're addressing the secondary causes of osteoporosis, and I hope that I've convinced you in my slide about pathophysiology that CFTR dysfunction is playing an important role in this. So what about modulators? So if we think about our first highly effective modulator, ivacaftor, it was FDA approved in 2012. So in a small retrospective study, it showed that there were increases in bone density. However, in a larger prospective study, there were not these, they did not find these same increases in bone density, but they did find changes in the microarchitecture. These patients were followed for 2 years. And then in a registry-based study, they found that patients with cystic fibrosis who were treated with ivacaftor were less likely to have bone and joint complications such as osteopenia and osteoporosis. Now, what about ETI? So this was FDA approved in 2019, and we have a recently published study from Minnesota that looked at the adults in their center and followed them, comparing their bone density measurement 1.5 years after ETI initiation. They continued to see a similar decline compared to prior to ETI initiation. However, at their second follow-up, which is approximately 4 years after ETI initiation, the bone density had actually stabilized. So definitely interesting to see what is going to happen as this continues. Now, again, Dr. Dara highlighted the PROMISE study. And so these results are not yet published, so please don't take a picture of it. And they've kindly shared it with us so that we can have it here. 36 out of 60 youth who were less than 20 years completed their 24 to 30 month study visit. And similar to the Minnesota study, bone density was declining at the 12 to 18 month follow-up, but seemed to have stabilized at the 24 to 30 month follow-up. And this is true of the total body less head, the lumbar spine, as well as both hip measurements. However, when we look at the adults, we have 50 out of 73 adults having completed their 24 to 30 month study visit, and the lumbar spine and whole body bone density was declining at 12 to 18 months and seems to have stabilized at the 24 to 30 month follow-up. So there's still lots of things to be understood about cystic fibrosis-related bone disease. We need to understand and characterize the natural history of CF bone disease in this post-modulator era in which so many patients are eligible to take modulators by genotypes. But I think, as has been really emphasized at that plenary last night, as well as multiple other talks, there are still patients who are not eligible for modulators. And so other factors such as genetic modifiers may be playing an important role in them, as well as the patients who are eligible for modulator. We also really need to understand who is going to be getting a fracture, not just the predictors of low bone density. And so maybe there's alternates to screening. Maybe that chest CT is going to be a really great option for us to be using. Increasing our understanding of primary prevention strategies. We have expert consensus recommendations for physical activity and nutrition guidelines, but not so much, data-based, as well as understanding what is our best therapeutic options for CF-related bone disease. Is it repurposing existing anti-osteoporosis medications, or is it potentially something that is specific and unique for patients with cystic fibrosis? So thank you so much to my research team, as well as my funders, and I'm happy to receive any questions.
Okay, we have a couple of questions that came in through the app. I think the CF Foundation guidelines recommend using T-scores in those over 30 years of age, and you mentioned using the score until 50. Can you discuss this?
Yeah. So the CF Foundation guidelines, I believe, recommend using the T or Z scores. And the ISCD, so the International Society of Clinical Densitometry, whose guidelines were last updated in 2019, recommend using Z scores for premenopausal women and men over the age of 50. Now, that said, what is expected, and let me just really quickly, this is perfect. What you can see is that for a person who is 20 to 50 years of age, they should really be having a plateau of their bone mass. They should be maintaining that. And so thus, if you're comparing them back to the peak bone mineral density of a woman who attains that in their 20s, the T and the Z score are going to be very similar in that, 30 to 50-year-old age population. However, we should be mindful that patients with cystic fibrosis, the large Canadian registry study by Jad et al. That followed 1,500 adults with cystic fibrosis showed that in that time period from 18 to 48 years of age, they were having declines in their bone mass. And so definitely want to be mindful of that.
Okay, and a follow-up question to that was, are other centers identifying or defining osteoporosis at greater than -2?
So a Z score less than -2 would be considered low bone density for age.
Okay. Yes, go ahead.
So it's sort of two questions, but how frequently are you starting bisphosphonates on premenopausal patients, either because they have low bone density with a fracture or they meet criteria for osteoporosis based on their scores, but they don't have a fracture?
Okay. So when I am doing this clinically, I'm doing this if they meet the diagnostic criteria for osteoporosis. And so for a person who's premenopausal, that's going to require a clinically significant fracture history. So in the first case, then we have the discussion of bisphosphonates. And I definitely recommend zoledronate a lot because for our adults, that's going to be a once a year infusion. It's low burden, additional burden for these patients. Now, for the patients who just have low bone density without a fracture, I'm really only considering it in patients whom I'm anticipating significant bone loss imminently, and so that's the patients who are being evaluated for a transplant.
And are there any thoughts of temporarily giving testosterone to jumpstart delayed puberty to improve bone health during their adolescent years?
So definitely, we think about inducing puberty in the patients with constitutional delay of growth in puberty. So that's a condition in which they're just a late bloomer. There's nothing really else wrong with them that you need to be treating and addressing. And so that's definitely a discussion with the patient and the family. Do we want to try some monthly intramuscular testosterone injections for 6 months? Stop it, wait 6 months to see if they spontaneously start puberty on their own. If not, try a higher dose of testosterone again for 6 months intramuscular. The reason to do intramuscular monthly injections of testosterone is so that we then don't suppress their own endogenous testosterone production. This is something that we really discuss as shared decision making with the family because they don't really like doing injections. And then because with constitutional delay of growth in puberty, we anticipate them starting on their own later. I wouldn't necessarily consider this as for the purpose of improving bone mass, but certainly if they're going too long, then we more strongly recommend this.
Okay, perfect. Trying to look at the time. Yeah, it looks like we have time for a couple more questions. Who would be best placed to decide the commencement and follow-up of HRT as a treatment for osteoporosis for postmenopausal women with CF?
So I would think endocrinologists would be well placed to address that, but I believe that gynecologists also often address hormone replacement therapy for this age population. So I think it would be whoever at your center is going to have an interest in understanding the complex physiology of patients with cystic fibrosis, as well as being comfortable doing those prescriptions.
Catherine.
Thanks, Melinda. My question is about the impact of fractures on people with CF. Are you familiar with data describing how fractures impact people with CF differently than other populations? And do you think that is worth studying, or is it just obvious that fractures are bad? I'm interested in your perspective.
So I think that this is absolutely necessary to be studied and very important. We have data from quite a while ago talking about the importance of fractures and how it causes increased morbidity. And there is a case report that is often cited to talk about how there's an increased mortality in patients with cystic fibrosis. This is a case report of an individual who had sternal fractures, vertebral compression fractures, and rib fractures in the context of an acute pulmonary exacerbation, who subsequently died a few weeks later after these fractures were diagnosed. And there's a lot of discussion about how having vertebral compression fractures is going to be causing back pain, how rib fractures are going to cause patients to not want to be doing vest therapy or airway clearance treatments, which we obviously can extrapolate are going to be causing them to then have declines in their lung health because they're not able to do their necessary therapies. But I think that we still really need to understand, is it otherwise impacting their quality of life, as well as these patients with cystic fibrosis, we really focus on their vertebral compression fractures, and they have quite a lot of vertebral compression fractures, but they're also experiencing non-vertebral compression fractures. And how are those impacting quality of life? In non-CF populations, a fracture increases your risk of having a subsequent fracture, whether that's a vertebral fracture or a non-vertebral fracture. And so I really do worry that our patients who are getting those wrist fractures are now at an increased risk of having a subsequent fracture. And yes, your wrist fracture, you can still do your vest treatment after that. But is that then going to increase their risk of having a vertebral compression fracture, which is then going to increase their risk of more morbidity?
Okay, one last question, and then we'll have time for a panel discussion if there are more questions that arise. Do we worry about pregnancy in bisphosphonates?
That is a really great question. So, bisphosphonates do theoretically cross to the placenta and could be having an impact on the unborn child. However, the data from osteogenesis imperfecta, nicknamed brittle bone disease, in which bisphosphonates are the standard of care, many women before they were childbearing have received bisphosphonates, and potentially even around the time of childbearing have had bisphosphonates, and their infants have been studied. Now, osteogenesis imperfecta is a genetic condition, so their infants may or may not have had osteogenesis imperfecta, and we're not seeing any impact in the infants, whether they had OI themselves or not. So this is definitely a theoretical risk. I think that this is something that should be mentioned to your patients, just like we mentioned the risk of osteonecrosis of the jaw or atypical femur fracture, because this is part of the black box warning, but I personally am not very concerned about it.
Wonderful. Thank you so much, Melinda. Excellent presentation. Okay, next we have Dr. Danielle Velez-Leitner. She's from Rutgers University, and she's a urologist.
Thank you. Hi, everybody. I'm excited to be up here to give a little bit of a different perspective. So I'm going to shift forward a couple of years and really focus in on male endocrine and reproductive health. So kind of past that adolescent, more into the young adult, adult lives. Going back, I do have 2 disclosures. I am a proud Envision member as well, Envision 3. I'm also on the sharing committee through the Cystic Fibrosis Foundation, and this year I received a grant as well from the Boomer Esiason Foundation. So really, I want to talk a little bit about the prevalence of male hypogonadism and cystic fibrosis. I want to spend a lot of time on testosterone supplementation options for men with low T, especially in the setting of fertility considerations. And then I'll talk a little bit about reproductive outcomes in males with CF. So why does this matter? I don't have to tell you guys in this room that life expectancy in people with CF has significantly improved. And living longer, healthier lives means that people with CF can now enjoy aspects of adulthood that weren't necessarily a guarantee before. So people are coming into the clinic asking about sexual health, reproduction, what does parenthood look like? How may I become a biological parent? And there are many aspects of CF that can affect testosterone and potentially vice versa. And that's where there's a really exciting realm of research and studies to be done. We know that with low testosterone, we're going to diagnose that between blood work and then also signs and symptoms. So blood work, early AM draws, looking for that total testosterone of up to 300 nanograms per deciliter, and on 2 separate measurements. So the reason why we harp on this is because testosterone will fluctuate around your time of life, around your time of year, even around your time of day. So we like those 2 separate measurements to be at least a couple of weeks apart. We're really looking for the peak of testosterone. So you can see in that B graph in the middle how T peaks in the morning. We want it when it's at its best. We know that it's going to drop down at some point in the day. We're not really sure when, so we try to get it sometime before 10 a.m. And not for nothing, insurance plans tend not to pay for T unless they get those 2 blood draws before 10 a.m. Signs and symptoms. So I try to box this out for my residents when they have a hard time really imagining and remembering all of these, but I think about it as exposures. So all the way to the right, chemotherapy and radiation patients are going to be at a higher risk of low T. And then chronic narcotic users, patients who need a lot of steroids chronically, they're going to have disturbance of their HPG axis. They're going to be more likely to have low testosterone. Other signs, unexplained anemia, bone density loss. We've heard a lot about that already. Diabetes, HIV/AIDS patients, pituitary dysfunction patients, and then male infertility patients all should get a testosterone panel done. And you can see how I've highlighted in yellow the signs and symptoms that are going to really resonate in our cystic fibrosis population. And then you've always got that patient that's going to come through looking with other symptoms. So reduced energy, poor motivation, low performance, low endurance, fatigue, depression, irritability, poor concentration or memory, and then really a lot of sexual health symptoms like lower libido, erectile dysfunction, orgasm changes, even genital paresthesias. Those patients I like to get testosterones on because it's a nice way of baselining it. And then when you replace that testosterone or supplement it, asking, did we fix it? How common is low T in men with CF? We're not entirely sure. We think it's probably around 25 to 35%. And it looks like it's happening at younger ages compared to the general population. This is limited, right? So we have small study numbers. They're mostly retrospective. We have no documentation of symptoms of hypogonadism in any of these studies. And we have very variable adherence to early morning 2 separate lab draws. So they're not perfect. But the 2 that I tend to look at, especially this one that just came out from our Emory group, this was a retrospective single center analysis with men with CF with a total T measurement. very well done, and that's almost 60% of their population had a T. But of that 60%, 28 were low. They found that it really didn't matter when the T was drawn, whether it was morning or afternoon. But interestingly, average age of that low T was 33 years of age. So that's pretty impressive. If I look at my practice, where 50% of it is guys with low T, not necessarily in CF, 1/3 of my 30-year-olds coming in where I'm like, wow, you're going to need T. That's impressive. It's usually, for me, it's more like 10 to 15%. Interestingly, diabetes is not a significant risk factor here, although they did notice that T was lower in males with CFRD. We also tried to look at this. Our institution didn't have enough to look retrospectively, so we looked at the TriNetX database, which is a global database looking at thousands of patients. And when we pulled the ICD-10 codes for males over 18 with CF or CBAVD, we found a couple of points. One was that we are probably underdiagnosing hypogonadism. Only 10% of males with CF had at least one testosterone measurement. Taking a step back as a reproductive urologist, I was really surprised by that because males with CF are infertile 98% of the time. So they should technically all be getting a T at some point if they ever present to fertility care. But for the guys who did have a testosterone drawn, we noticed that it was highly prevalent and at a young age. Again, average age of 40 years, 33% having a T less than 300 nanograms per deciliter. The good news being, though, that men with CF who are hypogonadal tend to get treatment, up to 60% of them. And this is really a nice hodgepodge of fertility-sparing drugs versus exogenous testosterone options. I'm not going to get into a ton of bone health and testosterone because I think we've already covered it. But, we know that sex hormones are important for bone mineral density and muscle mass. Part of the American Urological Association guidelines are that patients should be informed that testosterone therapy might improve bone mineral density and lean body mass. So that's something that we do like to track. If I have a patient in my practice who I'm worried about fractures, I do tend to get a DEXA scan at baseline and then a couple of years later just to see if we've made a difference and if they need referral to an endocrinologist. But again, most of these studies are done in older, frail men. And when we take another step and look at bone health and testosterone and CF, there are even fewer. So I think, again, like another really great opportunity here for research. In 2004, there was a study of 191 people with CF. We found that in the patients with CF who had a vertebral fracture, they did have significantly lower estrogen and testosterone levels. 2 years later, again, we looked at 40 males with CF, and we compared those to healthy age-matched controls. Interestingly, finding 28% of those patients did have low testosterone, but we also found a weak but significant relationship between bone mineral density and testosterone levels. The question then becomes, if we correct that T, do we make a difference? When should we be correcting that T? When do we test for the testosterone? And then if you're going to correct for it, one thing that I really worry about is as these guys are getting older and more presenting to fertility care, how are you going to counsel them about fertility-sparing drugs? So shifting gears a little bit, how do we treat testosterone? The first thing I always tell everyone is that exogenous T, so the gels, the injections, technically the pills, although that's sort of questionable. Exogenous testosterone is the closest thing we have to male birth control. All of these medications are going to negatively inhibit the FSH and the LH release out of the anterior pituitary. So when you don't get FSH, you don't make sperm. And when you don't have luteinizing hormone, you don't make endogenous testosterone production. Normal intratesticular testosterone levels are 50 to 100 times higher than that of systemic testosterone. So replacing it in the blood doesn't necessarily mean you're getting it into the testicle where it counts for sperm production. Depending on duration of exogenous testosterone use, it can take up to 18 months of alternative medications to really restart that HPG axis and spermatogenesis. So my first question to patients is always, what's your timeline? Do you want more kids? The answer is no. You also want a vasectomy? Great, let's do injections. But if the answer is we're thinking about it, or we're actually trying to conceive, or maybe in the next 2 to 3 years, I'm reaching more for these fertility preserving options. We really like selective estrogen receptor modulators like clomiphene citrate and N-clomiphene. N-clomiphene is a little bit different in that it has less of an estrogen effect. So patients tend not to see that estrogen bump when they start it, although it's a little bit harder to get from pharmacies. Note that this is an off-label usage of clomiphene citrate. So we really have to counsel patients when we're doing that. They tend to show up at the pharmacy and the pharmacist gives them a weird look. So you also have to warn them, hey, this is technically a female fertility drug, but where women may take it for a few days out of their cycle month, you are going to be taking this every single day for months. If patients come through my clinic and they've got a really high estrogen or testosterone to estrogen ratio of less than 10, then I tend to reach for the aromatase inhibitors first. So looking at anastrozole, exemestane, letrozole to really block that aromatization of testosterone to estrogen. And then you get this nice normalization where the T should go up and the estrogen should come down to a normal range. For patients who fail these options, 10% of Clomid patients are going to have a paradoxical drop in their testosterone. We move over to HCG injections where we're stimulating the testicle directly. And then finally, there's this fourth option, which is the intranasal testosterone spray. So this is a nice question mark option where it may actually maintain spermatogenesis. It's a 4.5% intranasal testosterone gel. It's given 2 to 3 times per day. The half-life is only 100 minutes. So these are basically not suppressing your pulsatile GnRH release, which allows for maintenance of FSH and LH, which you can see here in these bottom 2 graphs, that at 0, 3, and 6 months, you do have a little bit of a drop in your FSH and your LH, but it's not down to 0. And then when you look at the sperm production, although there is a decline in total motile sperm count, it's certainly not going to 0 the way you would expect it to have done in a gel or in an injection patient. There were 4 patients out of the initial 60-patient trial that did go to azoospermia. 2 stopped their therapy with complete normalization of their parameters within 4 months, and 2 were lost to follow-up. So this is another option that I like for patients if they're coming through and saying, I think I might want kids soon. I'm not totally sure. You're still going to have nice normalization of their testosterone levels. You're still going to have a nice treatment of any sexual health concerns that patient might come through with, but you're not necessarily going to tank their fertility in 3 to 6 months. Practical tips when I'm starting patients on some kind of testosterone supplementation program, it's ask about fertility. Remember that when you reach for that selective estrogen receptor modulator, it's a very central mechanism of action. So you're going to see less improvement in libido compared to your exogenous testosterone options, even though you may get the exact same T number. I personally like to repeat labs, looking at testosterone, estrogen, hematocrit, because we do worry about polycythemia for all of these patients, FSH and LH if I'm thinking about fertility, and then PSAs, so prostate cancer screening if they're over the age of 40. I tend to do that at baseline, and then 4 to 6 weeks after they start therapy so we can know what we did, and then every 4 months for the first year. After that, if things are going nicely, maybe every 6 to 12, depending on that modality. I think a lot about do we need to titrate the dose? Do we need to add an estrogen blocker? Do we need to switch the modality because you hate this? So I think also having that patient come back at about that 2 to 3 month mark really lets you ask questions about, did we fix what your initial symptoms were? So if your initial complaint was, I'm exhausted and I have no sex drive, and I've normalized your T numbers and nothing has changed, I don't know that it's worth the risk of maintaining that testosterone therapy for that patient. And then finally, for my fertility patients, again, especially if we're going for fertility preservation measures, considering repeating semen analyses and freezing sperm so that maybe if they do not like their HCG injections because they're super expensive, if they've frozen sperm, whether it's ejaculated or extracted, they can then more freely move on to testosterone, exogenous testosterone options. So how should we treat males with CF? If I have a 25-year-old that comes through and they are hypogonadal and they're thinking, well, I kind of want kids in 10 years, I might let them do exogenous testosterone, but really warn them that when it's time to stop this because you're thinking about having your sperm extraction, it might be painful for you to come off of these drugs because you're going to crash a little bit. So you have to be willing to give me that 6 to 9 month ramp of not feeling super great, but taking other expensive medications to restart your system so that we can get you to sperm extraction. Some patients say, well, why don't you just do the sperm extraction now? I'll pay the storage fees. I just want to feel better. Some patients are game to try clomiphene citrate or HCG. Some patients really want to try that nasal testosterone and see how it goes. But in terms of what's the best option, I think it really depends on what you and your patient shared decision making are going to come to. I get a lot of patients who are already on exogenous testosterone, and then they're surprised that they don't make sperm, and they're very upset. So we have to talk a lot about jumpstart pathways. So I think a lot about the Leydig cells and then the Sertoli cells. Leydig cells make testosterone, so that's where you're really reaching for your selective estrogen receptor modulators and aromatase inhibitors and potentially HCG as a heavier gun, versus Sertoli cells where you really just want to jumpstart sperm production. So that's where you're looking again at your recombinant FSH, which is like the heavier lift, versus you do get some FSH stimulation with clomiphene citrate and anastrozole, but it might not be as powerful or as fast as just giving them recombinant FSH injections. When we look at outcomes in previous exogenous testosterone users, very promising. So Wenker published in 2015 a protocol where patients stopped their testosterone, started HCG 3,000 units 3 times per week, and then also added in either clomiphene citrate or anastrozole, and then looked for the FSH recovery. If they didn't see it by 2 months, they switched that out for recombinant FSH injections. So if you are doing the HCG plus the FSH, you're really going to be giving yourself a sub-Q injection or an IM injection every single day. 98% of their patients actually had recovery of sperm production and or just spontaneous pregnancy after an average of 14 months of this protocol. Average recovery for just sperm on a semen analysis was about 5 months with pretty much normal average sperm densities. So that's very promising. In 2017, we had a study that looked at what is the probability of recovering that total motile count of over 5 million. And that group basically found that the longer that men are on testosterone and the older they get, they do see a decline in their recovery patterns by about 3% per year. So it's, again, something that I consider when I'm talking to a 19-year-old who's clearly hypogonadal, but maybe on this protocol for 10 to 15 years before they're really ready to consider having their own children. And then finally, just one more study to allay concerns that if you start the T, you're never going to get the fertility back. You can, it might, take some time. And it's very possible with HCG plus clomiphene citrate. A lot of patients will come through and say, okay, well, I really want to do testosterone injections. I really like how it makes me feel, but could we potentially prevent the azoospermia while we're doing this? And the answer is maybe. There's been very promising data with combined therapy between testosterone injections and small dose HCG. So this is only 500 IUs every other day. And we basically found that after that treatment, you did have normalization of testosterone from a baseline of 200 up to 1,000. And that total motile sperm counts actually were maintained over a 6 to 12 month period, up to a 3-year period, with baselines of 85 million and then actually going up a little bit to 87 million. Not clinically significant difference, but the fact that it didn't go to 0, I found really fascinating. Newer data coming out that maybe oral testosterone might also be helpful. This, again, is given twice per day. So usually with a fatty meal can cause some high blood pressure in certain formulations, but may have that shorter half-life, especially when you consider versus the intranasal testosterone options. So maybe this can also protect sperm concentrations while patients are considering their fertility potential. This group studied 54 men with intramuscular HCG plus oral T versus just IM HCG alone, and really found no difference in sperm concentrations or testis volume, which we tend to use as a proxy for sperm production. So another promising option that we can offer to our patients. Reproductive health, shifting a little bit further away from testosterone, we consider hypogonadism treatment as important because that 98% of men with CF are going to have obstructive azoospermia, but they're tricky. I can't ask them for a semen analysis and freeze it. I have to go in and get it, which means the patients are going to need procedures. It gets expensive. You have to talk about storage. How many times am I going to have to do this? And it also requires a lot of logistics and planning. In practice, we know that there can be worse reproductive outcomes in our CF patients and our CBABD patients. There are very few studies. The McBride paper is the one that we tend to pull the most. And this was done pre-modulator therapy. But what they basically found was that there were 10 men with CF, and they compared that versus 29 men with CBABD. And they found that there were significantly worse fertilization rates in the CF patients. So only 32% versus 69%. If you start out with 10 oocytes and only a third fertilize, you're going to have much lower embryo formation compared to that patient who maybe had a vasectomy and is also has obstructive azoospermia and also had to undergo that same procedure if their fertilization rate is more like 80%. So depending on what that couple wants, they may need to do this a couple of times, which means they need to have the financial and the logistical and the emotional and physical support to be able to get through all of those cycles. We very recently looked at our more up-to-date data. This is more post-modulator therapy. And this is combined populations out of Penn and Cleveland Clinic. And what we found was interesting, not totally in line with the McBride paper, maybe because we had because half our patients were on Trikafta. But interestingly, we did see that there were higher rates of, the FSH was basically higher in the CF patients, even with Trikafta and even with our highly effective modulator therapies. As reproductive urologists, we tend to use FSH as a proxy for spermatogenic dysfunction. So the higher the FSH, the harder we think it's going to be to find sperm in the future. What I think was really interesting here, though, was this kind of difficult to interpret graph. But if you basically look at the men with CF all the way to the left, you can see that up to 70% of patients in that group had very, very few sperm retrieved on their extraction, which means that we may be doing the same surgery, we may be preparing these patients the same way, but if we're getting very few numbers of sperm, there are going to be some labs that are going to be hesitant to even freeze that because we can't find it, which means on the thaw, which means that it's basically a wasted cycle. Versus patients who don't have a CF mutation, where you can see that most of those patients have many sperm when we do those extractions. So conclusions, and I'm excited to take questions, but so far it looks like about a third of males with CF have low T, and that tends to happen at younger ages. How this may change with highly effective modular therapy is to be determined. We know that normalizing testosterone a few months before your sperm extraction can help to improve outcomes, both in sperm quality and sperm production. And you really want to consider fertility, timing of reproductive care, and then patient preferences when choosing testosterone treatment methodologies. And finally, just a plug to connect with a reproductive urologist early because it can take time to really figure this out for the patient and that couple. That's it. Thank you so much. If anybody wants to come to the mic to ask any questions. So when you say early, and some of us are pediatric endocrinologists in the room, when should we be screening for these 300 times 2 samples? Yeah. I think that I don't honestly always know how to interpret testosterone in that peripuberal, immediate postpubertal patient. Mm-hmm. So I really can't comment there. I'm very much an adult urologist. Yeah. But I think that from a fertility perspective, I'm always happy to see patients if they just have questions and they just want to know and they want me to do a physical exam and say, well, what is my vas deferens status? Do I have an epididymis? What can I expect when I, start becoming sexually active? Early for like the adult patient, I like to tell my CF providers, give me like a year. So if they're thinking that they might want to get pregnant next year, send them on in and we'll have a conversation and just kind of get baseline labs and see what's going on. The worst that happens is when I get a referral and they're like, my partner's going to do her egg retrieval tomorrow. What can I do? I'm like, literally nothing. Like, you can hydrate today. And that's about it. Okay. So that's sort of a disaster for us. Yeah. Good.
One question. You mentioned the HPG axis may take about 18 months to recover. Does HPG axis recovery guarantee recovery of spermatogenesis?
Yeah, sorry, I should have been clear. That's really like my marker for recovery is the spermatogenesis. So and I think it's hard because if someone comes through and they were on testosterone, I assume they were on T because they were hypogonadal to start. So I don't really expect their natural testosterone to be amazing when they recover. But what I am looking for is just lack of suppression of the FSH and the LH. So once that starts to come back, and then I expect to see more sperm production in the ejaculate. But I've seen patients where you can really light them up with HCG and recombinant FSH, and it comes back in 5 to 6 months. And I've seen other patients that they want to take it a little bit slower, and then it can take 18. Catherine?
You mentioned, I think, that the rate of having a successful embryo through IVF is only 30%. Did I read that right?
No, that one was close. Yeah, so this was worse fertilization rate. So just that first day, the day after we basically inject that sperm into the oocyte, and then looking to see which one's fertilized. But if you have that significant drop off down to 30% on that day one, you can expect more drop off as you watch that hopefully blast form into day 5.
Do we know why that is?
We've got a lot of theories. I think there's a lot of basic science research. We know that the CFTR is expressed on the sperm. We know that inhibition of CFTR and even healthy sperm means that they don't fertilize naturally or at all sometimes. And I think that's really what we're trying to focus on with prospective studies now, is to try to understand, like, well, what are these reproductive outcomes? What are expected fertilization rates? How many blasts can you expect to form? Because couples want to be able to prepare and understand, if we want to have 2 kids, how many embryos do I need to make to have that happen? How many times do I have to do this to be able to make that happen? How much money do I need to be able to set aside to be able to do that?
And is any of this ever covered by insurance?
It is. It depends on the state. I just pulled this stat from, it's resolve.org, and they really follow a lot of the IVF reproductive healthcare guidance and like laws around the country. I think 24 states offer some insurance coverage, but that really varies depending on the insurance plan, how much you make, what they want to cover.
Great, wonderful. One last question. With the aromatase inhibitors blocking that estrogen, is there concern that that would lower bone mineral density over time?
So it's actually going to be my question for you guys, because I tend to not give it unless patients come through with symptoms of high estrogen. And usually that happens around like ease of like estradiol of like 40 to 60 is where I tend to see it. And usually my guys will come through saying, I just have a lot of nipple sensitivity, hot flashes, I'm way moodier. And then we give like anastrozole, maybe 1 milligram once a week. And they usually feel better. But I never want to drive that estradiol down under 10. Because at that point, men do come back in with a lot of joint pain.
No, I would definitely be concerned about hypothetical impacts to the bone.
Yeah.
And I think that monitoring their bone density over time in that situation would be very appropriate. And also, as you've emphasized, shared decision making, that we're addressing these symptoms, we're putting you at risk for this. And then if you did see a decline in bone density, a discussion of, and they may say that my symptoms are so bothersome, I don't really care.
Yeah.
Talk to me when I've had multiple vertebral fractures.
Yeah. I'm sorry. I'm not sure if her mic is on. Were you guys able to hear the answer?
Sorry. Just talk into it. Just look into it. Okay. Now can you guys go ahead?
Now? No. Oh, sorry. Sorry, guys. So I was saying to Dr. Velez that I would definitely be very concerned about the hypothetical risk because it's really estrogen at the level of the bones in both men and women, particularly in men. Estrogen is also important for ensuring that you're maintaining your bone mass. And so if you were reducing it, I'd be very worried about this. I'm not aware of any data that specifically addresses this, and so I was suggesting that you be monitoring and following the bone density trajectory and having a discussion with your male with cystic fibrosis that although you're addressing these very bothersome symptoms, you're putting them at increased risk of having low bone density and osteoporosis. And then if you were noticing that their bone density is declining, a discussion of the ongoing risk with this updated clinical information of do you want to continue, and really sharing this decision making in an area that we don't have data.
Yeah. All right.
Thank you so much. Excellent presentation. Okay, and we're getting ready for our last presentation from Dr. Perdomo Rodriguez. It's going to finish us off with talking about CFRD.
Good afternoon. You hear me well? Yes? Okay. Thanks for the plenary to invite me to talk about modern CFRD. I will talk about devices, expanded therapies, and addressing obesity. I have no disclosures. The objectives of my talk, I will talk about diabetes technology, mainly CGMs and insulin pumps. I will describe the increasing prevalence of obesity in CF and its implications in metabolic health. And I will discuss treatment with GLP-1 agonist therapy and SGLT2 inhibitors. So briefly, an overview of CFRD. We know it's one of the most common extrapulmonary manifestations of CF. The prevalence is increasing with age. The older you are, the more likely it is to occur. And it's more common in patients with more severe genotypes. Despite the low adherence rates we have with OGTT testing, it remains the gold standard. However, in Canada, the most recent guidelines do endorse A1C less than 5.5% to avoid OGTT testing, or if it's more than 6.4% because diabetes is basically diagnosed. Insulin therapy remains the established treatment of choice, but we know because of CFTR and obesity increasing, the landscape is changing, and we may be using medications that we thought were only going to be used in type 2 diabetes. And just simplistically speaking, we know that diabetes, CFRD, is characterized by partial insulin deficiency with fluctuating insulin resistance. So when we talk about devices, we tend to think about CGMs and pumps. I just wanted to briefly mention that we also have other gadgets that may be very helpful to treat CFRD. We use the smart insulin pens that allow patients to take very tiny amounts of insulin in half unit increments, and sometimes they come with apps they use in their phone to calculate better how much insulin they should be taking based on their dietary intake and sensitivity to insulin. We have insulin patches, so patients who don't want to be injected multiple times. You have the eye port where you can inject insulin through the port and only replace it every 3 days. We have insulin patches, like on the left and the right hand of the picture, that patients will put it every 4 days and take insulin just pressing a button, fast-acting insulin. But I think one of the most important devices out there is the CGMs, and you can see here multiple CGMs in the market. They're all inserted like the girl in the picture, but one of them is inserted with a small incision, and that lasts several months, as you see here. Unlike glucometers, CGMs measure glucose in the interstitial fluid and not in the capillaries. So that's an important distinction to make, because sometimes they may not give you the same glucose values for that reason. So what benefits bring CGM? So I think I see this in practice, and the evidence shows as well, and that they decrease disease burden. And in type 2 diabetes, type 1 diabetes, using CGM is associated with decrease in A1C. I definitely believe that they improve patient engagement, education, empowerment, and they help me teach my patients and design specific goals and strategies that we will be developing over subsequent appointments. And importantly, it's really important for telehealth platforms. And even at UF, where I work in Gainesville, we have CGM reports integrated into the Epic EMR, and we get reports about patients every 2 weeks, where we know, okay, these patients are not doing well. Let's find out. Let's reach out to them and see why. So this is what a CGM report looks like. So it gives you a glucose average, and the GMI, which is an approximation of A1C, a measure of variability, and the targets, which I will define now. So we have the time spent above 250, which we want to be less than 10%. Now, this is based on type 2 diabetes ADA recommendations. The time in target range between 7 and 180, which we want to be about 70%. In more complicated patients, about 50, type 1 diabetes and more patients with more morbidities. And the low in light red, less than 70, could be 4% or less, but very low, less than 55, should be 0%. And every percent is about 50 minutes. So 4% is about an hour for hypoglycemia in any given day. So there are surveys that have surveyed patients with or without CFRD, and they want to know what they think about these devices. I just highlighted the most important or the most common ones where there is more agreement. So they agree that it makes diabetes easier. And they like alarms because they feel more secure with them, and they don't have to do as many finger sticks. and they help them monitor diabetes during exercise, but there are also burdens, and the same burdens will apply to insulin pumps. They think they cannot be trusted, and I think that's because we probably should be doing a better job educating patients about the nuances between glucometers and CGMs, because they measure glucose in different compartments, and sometimes, depending on when you're checking, they could give you different numbers. Unfortunately, they remain sometimes unaffordable, and I was surprised to learn, preparing for this, that there's a lot of a stigma around the use of CGMs. I don't know if that's improving. I do see a lot of people who don't have diabetes wearing CGMs, in the population at large. So we have multiple pumps, and I don't think we can tell that there is one single best pump out there, but I think a pump is better than any pump is better than multiple daily injections. You will choose pumps based on the size, the cannula, is it long, is it short, or is the pump tubeless, like we can see here. And most pumps now are automated or closed loop systems, meaning they are in closed loop with the CGM, and based on glucose trends, they can modulate insulin delivery up or down, or even suspend insulin when patients are going to have hypoglycemia. So there's some studies in CF. This study was a randomized open-label crossover trial of 20 adults. They used the iLet bionic pancreas. I explain later what is particular about this pump. And basically all the glucose parameters improved. What I was surprised about is that there was no difference in variability and no difference in time below range, which in type 1 and type 2 diabetes, we do see pumps help. And even though there was no difference in time below range, there were more episodes of symptomatic hypoglycemia that was reported by users. You can see here that pretty much everybody had an increase in time in range, about 12% increase in time in range between 7 and 180, and 3% has been deemed to be significant clinically. And what is important about this pump is that the patients don't need to count carbs. We don't need to set, basal rates and carb ratio sensitivity, and it's much easier to start someone on this pump because all you need is the weight. And the patient will announce what they're eating. So I'm eating my breakfast is a small, usual breakfast for me, lower than usual, and the pump will learn fairly rapidly and get those blood sugars down to the range that we want. There's studies with other pumps. So this is a non-randomized study of 46 patients that were using multiple other pumps against multiple daily injections. And again, same findings. But this study also looked at changes in body composition. And as you can see, there was an increase in fat-free mass, as we know is very important in CF. We also have this study that use Omnipod 5 as a closed-loop system with the only tubeless pump right now in the market, although it's a new coming up or recently approved. And same findings, I just wanted to point out that 46% of them attain time in range more than 70%, which is the what we want to aim for in most diabetes, more than 70% time in range, and about 50% of those did get there. And again, no difference in time below range. And importantly, in this trial, one person had one episode of he had a hypoglycemic seizure, and it's not clear when I read the study why that happened. It was not because the patient forgot to eat when they bolus, or it was not because of a late meal announcement, but it does happen. Hypoglycemia is still possible. Regarding benefits and burdens, the same thing. So same thing I mentioned about CGMs applies to insulin pumps. And also the same burdens. Again, painful to wear, expensive, and a stigma appear to be the main ones. So in practice, I think that these are the most important barriers. Alarm fatigue is a big one. So patients may like how pump works, but then they don't want to be woken up, at night with alarms about going up, going low. Pumps do tend to be different in that regard, but there are strategies you can implement to limit alarm fatigue. In patient engagement, which is some pumps will require patients to learn carb counting, and they need to interact more with the pump. So now we're comparing pumps in regards to how much patient interaction there needs to be. stigma, as I mentioned, and connectivity with the CGM. So it's important that endocrinologists see these patients and always thinks, okay, what could happen if the sensor wasn't working? I need to program the pump or have a backup plan in case the CGM was not working because the pump will not be smart anymore. So always to remind ourselves that every challenge is an opportunity. So surprisingly, the discontinuation rates of CGMs and pumps are about 4 times more in CF than they are in type 1 diabetes. And I don't know why that is, but probably we have to expand the education to the community as well as patients with CF. So now, shifting gears to obesity, we know that even before ETI, the incidence prevalence of obesity and overweight, obesity in gray, overweight in yellow, was increasing. And not surprisingly now, even worse with the ETI has all tripled. Since in 2024 compared to 2004, the prevalence of overweight and obesity has tripled both in pediatrics and adult patients. Now, we know that the higher the BMI, the better the FEV1. But we also know that around a BMI of 23, the FEV1 kind of plateaus. So what happens if we keep going with BMI? And so I took these two quotes from different studies, but I first wanted to show this study where they tried to analyze patients based on their pancreatic status. So if they were pancreatic sufficient, they are high risk for BMI and metabolic complications. They actually saw the BMI, the FEV1 started going down once the BMI reached 85th percentile, whereas patients with pancreatic insufficiency, the BMI kept increasing. So the authors concluded that having BMI more than 85th percentile may be detrimental. In adults, though, we don't see that dip. However, there may be more risks with obesity than there will be benefits with larger BMIs in regards to FEV1 because the benefit is very, very small once the BMI, as you saw in the previous slide, there's a plateau. So what complications do we see in because of overweight and obesity in CF? So we have sleep apnea, we have distorted body image, hypertension, and I can show based on these findings of University of Minnesota, where they looked at about 500 patients between 2015 and 2017, and they found that patients with obesity were more likely to be older, be male, have pancreatic sufficiency, be diagnosed later in life, have a milder CFTR genotype. I'm not surprised, so we can talk about why I say this, but I'm not surprised the prevalence of CFRD was the same, whether you had obesity or not, and also not surprised if everyone was best in patients with obesity. They found this patient had significantly higher cholesterol levels, significantly higher triglyceride levels, but they were only modestly elevated, and actually the LDL total cholesterol, they were within normal ranges. So it's unclear what this will mean clinically. Of note, in the study, they also found an increased prevalence of hypertension, and they had a good amount of patients that were older than 50, about 20% of them, and none of them had cardiovascular disease despite those findings. I tried to find evidence-based guideline recommendations of what to do with these patients. I could not find any, so that's why you see question marks. Do we have to extrapolate recommendations from type 2 diabetes or population at large to CF. I would say, though, that I would worry about rapid weight loss because rapid weight loss can be associated with fat-free mass loss, which is not something we want in CF. And we know we must concentrate our teaching on healthy eating, so including whole grains, healthy fats like fish and omega-3 fatty acids, and lean meats, avoiding processed foods, avoiding added sugar, avoiding fructose syrups. But that basically, we don't know much about what we should do. However, we start now, because of diabetes as well, learning about this because now we have GLP-1 agonists and we have SGLT2 inhibitors. So we'll not spend too much time on this slide. Just wanted to mention that GLP-1 agonists are incretin hormones, so they increase insulin secretion in a glucose-dependent manner, which means that patients will not get hypoglycemia if they're used alone, but they can get hypoglycemia if used with insulin. And they have receptors in multiple other organs. Maybe that's why they have earned multiple FDA-approved indications that you see in the slide, like obesity, type 2 diabetes, sleep apnea, is a big one nowadays, at least in my adult practice, cardiovascular disease prevention, fatty liver, microvascular complications like diabetic kidney disease. And these are the risk factors that we spend most of the time discussing with patients and physicians. Is really a risk of pancreatitis, and I think that's controversial in type 2, thought to be less of a risk in people who are pancreatic insufficient, gastroparesis. I do see a lot of that in my patients with or without CF. Unique to CF patients, bowel obstruction, quite common. Is there a risk of retinopathy? That's also controversial. But again, as they gain more weight and the longevity increases, then we will have to balance that with the potential benefits like nephroprotection, cardiovascular risk reduction, and weight loss. So we have these two studies, and just want to mention that Amir has this poster where they looked at these medications for patients with obesity and overweight. They published research. We have a case series of 5 patients, and they all have pancreatic insufficiency, obesity, CFRD, and they were on ETI. Now, not surprisingly, they lose a good amount of weight, but I wanted to point out that the FEV1 remains stable or improved in all of them. 1 out of 5 discontinued therapy. Unlike this other study, where it was retrospective, and they follow patients with or without diabetes, with or without pancreatic insufficiency, and again, a good amount of weight loss, but again, FEV1 remains stable as well as FVC. But importantly, they noted patients decrease insulin about 31%. It's very important that we remember that, because patients can develop severe hypoglycemia if they respond really well to GLP-1s. SGLT2 inhibitors, the other medications, these medications are oral, all of them, GLP-1s, some of them are injectable and some of them are oral. They block the glucose sodium transporter and thereby decreasing the reabsorption about 90% of the glucose filtered by the kidneys. And they have multiple other benefits, but the approved clinical indications so far are cardiovascular disease prevention, especially heart failure, and decreasing the progression of diabetic kidney disease. Obviously, also they treat type 2 diabetes. And these are the potential complications. So in ketoacidosis, we see that in type 1 diabetes, but it can happen in type 2. I've seen people really sick in type 2 with this. Frequent side effect, genital mycotic infections, I think is the biggest one with them. Fractures, question mark, because this was a finding of an early study called the Canvas trial that was looking at cardiovascular protection with canagliflozin, but this was not a finding in subsequent studies. And I put here avoid when sick because I would not use, now I think we need evidence-based guidelines of when we could use or should use these medications. But me personally, I wouldn't use this medication if someone has a very high A1C. Why? Because I worry that they have become insulin deficient, either because of glucose toxicity or because the disease has progressed. I will counsel them to stop the medication if they get nauseous, if they're vomiting, if they're going to have planned surgical procedures. And again, with the increasing prevalence of obesity and longevity, we have to learn about these medications and become comfortable, because we start seeing more and more complications in people with CF. I have in my practice a few patients with microalbuminuria that I have been prescribing empagliflozin to decrease albuminuria, and they work. I've seen, again, mixed results with glycemic control, but I do see the kidneys and the protein in the urine decreases. And this may be important for CF as well. There's recent data that they may decrease the incidence of kidney stones because they interfere with the metabolism of calcium and phosphorus. I don't know if Melinda has any input regarding this and bone health, because subsequent studies didn't find any increased risk of fractures, but interestingly, they decreased the incidence of kidney stones. So this is a study that looked at 8 patients with CFRD, and you see some important weight loss. Importantly, FEV1 remained stable or improved, and again, we saw the mycotic infections. So to conclude, just wanted to remind the audience that CFTR modulators are increasingly being used. Obesity is increasing in CF. They are changing really the management of CFRD. So now we're using these medications previously known to be only in type 2 diabetes, but we need more research. Diabetes technology is very important. It makes life easier. It improves glycemic outcomes. I think everybody does better, and I hope they take up more and more and more. And just be cautious with look for cardiovascular complications or risks for cardiovascular disease in people with CF who are developing obesity. Make sure you are checking those lipids. I noticed that we don't do a good job with that, and trying to let go of the nutritional legacy in CFRD and start discussing more about food quality. Thank you.
Wonderful. Any questions? I have a question. I know Dr. Mohit is leading and I think University of Pennsylvania multi-center studies on looking at the safety and effectiveness of GLP-1 and receptor agonists in CF. But many of us are starting to use it in our clinical practice. Given the GI manifestations of CF, are there certain patients that we should avoid using GLP-1s in, like bowel obstruction, history of bowel obstruction, DIOS, things of that nature?
So I was very surprised when I read both publications I shared, because they did include patients who had gastroparesis, and they also included patients who had a history of bowel obstruction. So those would be the patients I would be cautious with. I think we need to spend some time trying to understand what is their baseline GI symptomatology. I personally don't know the prevalence of gallstones in CF, but you know that if patients lose weight rapidly, they tend to develop gallstones, and that could be a risk for pancreatitis. I can only extrapolate that from what I know or what I see happening in type 2 diabetes. I think nausea and vomiting are very, very common. So I've used this a few times in CF. I do see some nausea, some vomiting, but in the studies that we have, they were able to increase semaglutide to 1 milligram, which is a big dose, I think, in CF. And they even, the retrospective study I saw, they were using Mounjaro, tirzepatide, up to 50 milligrams weekly, which is the maximum dose. So I don't know. I don't know exactly.
Yep. More to come from Dr. Mohit's group. Yes.
I was curious, and I don't know, I'm newer to the clinics as a nurse, but I'm a CF parent. And I was curious if you see if there are clinics that are currently replacing oral glucose tolerance tests with continuous glucose monitors, or if that's going to happen in the future.
So I can tell you what my bias is, my own bias. So I always ask myself, sure, I can diagnose diabetes, but am I going to do something about it? Meaning, will there be treatment that I can offer a patient right now? We know that doing OGTT is not fun. I've done it myself multiple times in one day. Once I volunteered for a study, and it was not fun. I vomited. We have patients who have severe hypoglycemia with the OGTT, but sometimes I'm like, I wasn't surprised it was normal. Is someone who's not losing weight, has perfect FEV1, the A1C is very low. Do I really need to do it? So I like the Kidney guidelines, and there are a few studies that looked at using A1C values, not as a rule in, but as a rule out, which I think is an important thing to do, to rule out CFRD and focus our energy on those who may really have it.
Hemoglobin A1C values are less reliable.
Yes, they are indeed less reliable. That's why when, so I mentioned A1C 5.5%, the Canadian guideline, but normal A1C, so you may diagnose someone with prediabetes if more than 5.7, diabetes more than 6.5%. So lower A1C would therefore, even though it would be falsely lowered, very low A1C values may be enough as a rule out test. And that's what the studies have shown. So if you have a really, really low A1C value, if you do an OGTT, you may find out that it's actually normal. And in the inverse is true. If the A1C is already 6.4% or more, A1C diabetes is 6.5% or more. So you could avoid doing it that way too.
Thank you.
Yeah, currently we're all still following the CF Foundation guidelines, but there's definitely a lot of study with CGMs or even using like a non-fasting 1 hour test. So lots of research still to come to see if
we disclaimer, my own bias is because we.
But I think currently, if you like, for us as a family, if we were to do a CGM instead of doing an oral glucose tolerance test, I think it would negatively impact our clinic statistics, if I remember correctly, because the clinic is kind of like, I don't know, but how many patients do you have doing OGTTs?
Right. Yeah. We still try to follow the guidelines. For us personally in our clinic, some children will bypass getting the oral glucose tolerance test if they have vomited multiple times in previous times, or if they have severe hypoglycemia afterwards, which I feel that the oral glucose tolerance test might cause more of a risk if I'm looking for hyperglycemia. So for that, I'll bypass, and there is room in the registry to put in whether a person received a CGM or not. We still try to follow the guidelines. Just a plug there.
Hi, I'm Mary Rossi, Tulane University, New Orleans, pediatric diabetes and obesity medicine. And I manage our CFRD patients. First off, thank you for mentioning the lipids, because I'm also the lipid doc, and I have to brag on my doc because she does check lipids, and we've diagnosed a heterozygous FH patient who their pediatrician didn't catch.
Wow.
As we start to, so I use GLP-1s in my non-CF patients, and clearly I'm going to end up using them in our CF patients. But I've started to worry about my adolescents, in particular, my adolescent girls and their bone health. So I guess I'm going to encompass a lot of y'all. And I'm starting to, as we're listening, be concerned. I guess I'm looking for a little guidance on what to think as I'm using these in our CF patients on like monitoring. I know there's the standard guidelines for monitoring in DEXAs, but are these patients that should we be doing baseline DEXAs before we start these patients on GLP-1s because they're higher risk than our average?
So
Do we need to be more aggressive? I know there's no guidelines on it, but it's going to happen, and we're going to have to start doing it without guidelines. And so I'm just looking for best guesses.
Yes, I will defer to Melinda about that, but I think there are receptors in the osteoblasts of GLP-1 receptors, so GLP-1 may actually have some benefit in bone health, right?
So it may, and I would say that yes, we don't really have data to drive any guidelines. And so if you are getting a baseline DEXA before you start, and then you're starting them, and then you get your follow-up DEXA, you will be the one who's generating that data that's going to help drive the guidelines.
And thank you in advance.
Yes. Yes. Yeah.
Yes.
In which case, my boss would say do it as well.
So I have two kids with CFRD, and one of them he was actually one of those lines in the bionic pancreas trial. Are they still enrolling for that?
My understanding is that
I can speak to that. Yes, we are still
Right.
enrolling
Well,
for
if
that.
anyone has a kid that is already on a pump or not on a pump, I highly recommend it. After the trial, my son was almost in tears when he found out he wasn't going to be able to get it. So we fought our insurance company and got back on it, and his numbers are great, and he loves not counting carbs. I can't even tell you how it's changed his life. So.
Thank you.
For those not familiar with the study, it's a study that's using the new pump called the iLet pump, which is very unique in its features that you do not have to put in how many carbs you're eating. You just have to put in whether you're having a small meal, a medium meal, or a large meal. It's a very different way of doing diabetes than we're all used to. And so it's very user friendly. And so that's why it's being used to see whether this should be used in CFRD or not.
Thank you. So we have just a few minutes. There was one unanswered question in the chat, and this is for Dr. Velez-Leitner. Can the different methods of sperm extraction influence the amount of sperm extracted post-wash in CF men?
That's a really, really great question that we don't have answers to. I think that we're trying to build a retrospective, larger institutional database to answer that question. We also want to know, is there better sperm quality if we take it out of the epididymis versus the testicle? Sperm quality tests are really difficult because they just inherently destroy the sperm. So if you only get 10 sperm and then we destroy 9 of them to know that they're good quality, what are you really doing? I think the other question is, it really depends on your patient. So yesterday I was in clinic and I saw a guy who just one side has no epididymis and the other side had maybe a very atretic epididymis. So am I really going to go poking around in there and causing a hematoma? Probably not. I'm just going to go straight to the testicle. So I think it really depends on what you see. And then when I'm in clinic, it's a lot of shared decision making with the patient. So do you really want me to bring you to the OR? Do you really want to do this in the office? What will your insurance pay for? What can you afford? How much discomfort are you willing to tolerate in my office? Are you okay doing this a couple of times if it means a lesser invasive approach? So that's mostly how I manage these patients. We have surveyed other reproductive urologists, and it seems like that's also how they manage their patients. So in terms of best practice, there is none. I think it really just depends on what do you have and what is the patient up for.
Wonderful. We have a few minutes. Any final questions? If not, we'll give you a few minutes back for getting ready to go to the plenary. Thank you so much for your time.